And this will be shared later on YouTube. Okay, I'll share it on the different groups. Fine. So welcome everyone. Thank you for taking the time. This is basically just hopefully a quick chat about the different questions that you've asked on the groups, and thank you for everyone who sent me questions. I've got around 50 questions. Okay, obviously feel free to interrupt. That's the whole point. Ask as many questions as you want. I've got maybe 2 hours. Okay, so that should be more than enough. Hopefully it'll be less. All right, but don't be shy on raising your hand and asking if you wish. And issue is that I don't usually look at the chat here because I'm too sort of busy discussing other things. So ideally, raise your hand and speak out if you can. Yeah. Otherwise, I'll look at the chat later. But please, speak up. It's always more useful. I'm going to focus mainly on the new curriculum. All right, the new portfolio pathway, not the old CESR route. We will. If there are questions on the old one, we don't mind discussing as well. But as you can all see, that the main questions are the new one, not the old one, for obvious reasons. So just when you ask a question, just try and be clear on which pathway it is, because that will be more confusing for others. Okay, so as much as you can, try to specify which route are you taking. Okay, fine. So I will start straight away. I will share you the screen as well to show you some other stuff if we can. And apologies if lots of questions here are pretty basic, but I hope you find it useful. Okay, so the first question is CRS1 needed for each specialty? CRS1 is the conduct a consultation. I'm sure all of you are aware of it. And for those who did the old one, it was only one outcome. So technically speaking, you only needed 2. If you look at the new one, in the Excel file, you'll find it in each specialty. So does that mean that you need it for each specialty? My advice is yes. Okay, so aim and do it for each specialty, obviously depending on which level. So if it's in level 3, do one here. If it's level 4, again, do the same. That would be my opinion. Okay. The issue is, again, there's lots of debate. Someone else might say, no, you don't need it. It's a bit vague. Okay, so you'll find me answering this question with the same reply every now and then, that we're not entirely sure, because as you all know, that no one has been assessed yet through the new one. So we can't know for sure unless someone comes back saying, oh, I've done that and I've done this. Yeah, and I'm really eagerly waiting, to find that person. And then just to to have a chat with them as well, to get their experience. Okay, hopefully soon in the near future. But my advice, as always, is do more rather than less. Okay, that would be my suggestion. Okay, and as the old one, again, in each outcome you'd aim for 2 pieces of evidence. Okay, not necessarily 2 forms, 2 evidence, meaning that lots of outcomes can be ticked off by the FRC off, for example, which is fine. So let's say something not practical. Yeah. So any skill that is not practical, whichever that is, something theoretical, whichever outcome that is, this more applies in the old curriculum. And again, if you remember, there was an Excel file shared out there that lots of outcomes can be ticked off by the FRC off. So those one, definitely you just need another piece of evidence, and that's it. For the new one, there are no learning outcomes per se. Yeah, so I'll show you in a bit the new website. I'm sure everyone has looked at it already. The outcomes in the new curriculum are very vague. Yeah, so for example, in glaucoma, it tells you to be able to assess and manage complex glaucoma cases, for example. It's a very vague outcome. So is it a particular outcome to link to a specific form? Not really. Okay, so it's just a general learning objective, let's call it. Yeah, unlike the old one, when it was very specific and you need to fill out all of these outcomes. Yeah, in the new one, it's a bit more flexible. So it's a more of a portfolio assessment, your general sort of assessment. So your learning outcomes for the new one are the Excel file. Okay, not the learning outcomes per se. It's the Excel file points. So DOPS, OSATs, TAB, squints, whatever. whatever is mentioned in the Excel file. Okay, so I'm hoping that is a bit clear. That's why I'm saying that if you find the CRS here and the CRS there and here, for each specialty, you'd aim to do obviously ideally 2 of each. But that is debatable in itself, because if you look at the Excel file, it will tell you there are alternative forms of assessment as well, not necessarily the CRS form. You can justify being able to take a history by providing logbooks. So you've mentioned the logbook that you've seen many cases and you've taken history from cases, testimonial, for example, a letter, whatever. It will be sufficient. But again, my advice is always aim to do more forms rather than anything else. Forms are very strong evidence. So whether it's DOPS or CBD or whatever, these are all strong. Yeah, that because someone else has seen you do it and they can comment on your practice. So aim to do more forms rather than letters or anything else. Okay. Is filling the brief description of the case sufficient? Definitely not. Okay, so assume that person is asking about a CBD, for example. So you find a box at the top where it asks you to give a brief description of the case. Very summary, so 50-year-old presenting with acute loss of vision, pressure is this, diagnosis is angle closure, for example. So that's the brief description. What you want to write down is down there, so there's a box with, saying what especially is good or what could be better or whatever. These are the points that you need to fill out in detail. Okay, so the more the better. So just to satisfy the assessor that, you've managed the case. Luckily, and we'll repeat this later, as I've said, there is no outcomes to associate it to the forms. Yeah. Although, that is a bit debatable as well, because I think someone mentioned somewhere that you still need to associate outcomes, but I don't think that is the case anymore, because as I've said, the outcomes are very vague, very general, unlike the old curriculum. Yeah, so in this one, you just need to submit the forms. You don't need to associate anything at all, right? But that is still, I'd say it's a bit debatable still. I can't be sure. I'm pretty honest with you guys. So lots of things that we don't know yet. So keep it on the side. So maybe for those who are attending the, the training days, maybe ask, do we still need to associate outcomes? But my understanding is that you don't. Okay, but keep it on the side. Just question mark on the side. Okay. Can we change the DOPS or OSATs form to make it for each learning outcome? Yes, because the forms are generic. Yeah, so when you download it, it just says DOPS or OSATs. You have to add next to it, what's that? Oh, what's that DOPS? Is it local anesthesia? Is it removal of a corneal foreign body? Whatever. So you add a text box to tell the assessor which one is this. Yeah, and the same for all forms. Okay, and call that the association. Okay, so you're going to add a text box at the top. That is the association. So you're going to link it to a specific outcome in the Excel file. Right. Does EPA need to be a consultant or professor? I'd strongly suggest a consultant. Yes. Obviously, in the UK, it doesn't need to be a professor. Elsewhere overseas, if you're working in a university hospital, they are professors, but and consultants. So ideally it needs to be a consultant, because it just doesn't make sense to get someone who's not a consultant to sign you off for this specialty. It just looks weird. So my suggestion is definitely get consultants. Okay. EPA, by the way, are not entirely mandatory. Okay. Again, another debatable question. Is EPA mandatory? Not necessarily. If you have got a clinical supervisor report, let's say, again, a very common scenario that you've got some evidence from the old pathway, and now you want to shift. You're not going to be able to make it in time, so you want to carry on using the new one. Are you going to throw that old CSR in the bin? No. Okay, so you're going to keep it. Let's say it's glaucoma or whatever. You'll keep it, and it should replace the EPA. Okay. But as always, I always suggest doing more rather than less. So if you can get an EPA, that would be best. Another option is getting a letter from the consultant, again, just to summarize what you've done and what you've learned and what your abilities in that specialty. What did you manage? So if you get the three, great. But it would be very risky to get nothing, so at least a letter, it just shows strength, in your application when you get these forms signed. It's like a sign-off form. And we try to get to do what the trainees are doing. So the trainees are doing EPA forms. So try your best to do them. Okay. Logbook overseas. Do I need to provide a photo of the folder or the verifier is enough? So what that person is saying is it enough to put the surgical cases in the logbook and that's it? Or do I need to provide extra evidence that these cases are actually real? For some reason, we always are a bit defensive. We always assume that the GMC will not believe us or will not take our evidence into account for some reason, especially if it's overseas. That's not the case, okay? Remember, that's why the verifier is there for. So they will get in touch with that verifier, and if they had a look at your evidence and they can confirm that your evidence is true, then that's fine, yeah? Make sure that the verifier overseas has got a work email address. I believe that some people have got verifiers overseas that do not have a work email address, but it just looks very suspicious, okay? They do email them to confirm that this person is real and who they are or where they work, but I'm not entirely sure about the exact process. I'm not sure if it's like a form to fill or is it like an online, I don't know, image or video, for example, like online banks, they do like a selfie or, a selfie video just to confirm that person. So just to avoid all of that hassle, just get a work email address. Okay, that would be the easiest option. Okay, fine. I'm going to try and answer the questions in the chat at the end. Okay, let me just finish those first, and then so feel free to ask questions in the chat. Yeah, fine. Requesting to show an example of how to fill out a form and how to use it. Okay, that I can do. Let me get an EPA up there. Share the screen. So this is an example of the EPA. Let's go. This one. Yeah. So this is the EPA one for general ophthalmology. Okay. Obviously, again, you do know that you don't need the forms inside of it anymore, which is a big advantage. Okay. If you've got a nice consultant, a supportive consultant who has seen you work for years and they're happy that you can do all of these skills, you don't actually need to show them the forms. Okay, so you just click, choose an item, yes, and then has been checking visions for my patients for years, for example. Also, I've seen them, assessing pinhole vision, whatever you want to write down. Yeah, obviously, the more you write down, the better. As if it's like a reflection of that assessment. Yeah. And at the end, if they're happy, they're going to sign it off, and that's it. What if you've already got these forms, whether it's the new one or the old forms? That's fine as well. You can use it. So yes, you're going to write down submitted a form, a CRS form, for example. If you want to add some more details, that's fine as well, but just keep it sort of simple. Yeah. And the same goes for everything, but make sure that everything is ticked off. Okay. Gonioscopy is a bit weird. That's a new one. That was not there in the old curriculum. But still, because it's in the EPA, you don't necessarily have to do it, which is extremely weird, in my opinion. Yeah. These skills are essential. I'm not sure why they're a bit lenient with them. So that means that some people out there, they've never done a gonioscopy before, but still, because their supervisor is chilled and a friend, they'll sign it off and that's it. So it's a bit risky and it's unfair, in my opinion. I think because some people won't be able to get the form signed without actually doing the forms. But I think it's then in their benefit, just to make sure that they can do actually these skills. Yeah. And then at the bottom, just write competent, and then anything especially good, you write whatever you want, and then what additional evidence, if any, that is needed. Obviously, you don't need to write anything there, but maybe write down that he's going to attend this course, or he's going to focus on this skill, going to train more, whatever. Yeah. So the question is again, does the consultant need to sign somewhere? Not necessarily. Okay. So you just write their name there, the status, which obviously is a consultant. Do you want to sign? He can sign. Why not? Again, that would be my suggestion. If it's easy, you don't necessarily have to. Okay. But my suggestion is get them to sign. Again, the other question is, does that need to be on 14 Fish? Not necessarily. I'm sure everyone knows how people are struggling with the 14 Fish, so you don't necessarily have to use it. Issue is that some consultants like it, and it's their easy way of doing things, and they're used to it, so they don't mind 14 Fish, and they sometimes ask you, please send it on 14 Fish, nothing else. If you're lucky and your consultant is flexible, then the other options would be to download the forms, as we've done here, and then sign it off electronically, even without the signature. Okay, just leave it, just add their name, that's it. If I were your consultant, I would say, let's arrange a meeting next week and get you all the forms, get the forms with you on your laptop, and then we'll fill them together half an hour or so, and that's it. The last option is download it, print, fill, and then scan, which is a bit longer, a bit tedious in my opinion. And then there's the risk of handwriting issues and stuff. So maybe fill it electronically and then print it off. Perhaps see what's best with your consultant. Okay, so just do whatever they find easy for them. Okay, so I hope that answered the question. It's not tricky. Fine. What else? Where we? How to get a consolidation report or logbook from Medisite. The logbook from Medisite is not mandatory. Okay. So the surgical logbook, Medisite, for those who are not in the UK, it's the electronic record system that we use here in many trusts, and then where we put all our surgeries and clinics and stuff, and then you can download a report with all of your cases, which is fine. It's quick. There is no option to do a consolidation sheet. I believe so. Again, I'm not the IT expert, but if someone knows, I don't think there's an option. There's the audit option. You can filter out the cases and you can know which cases that you've done, but there is no option of generating a report saying, okay, you've done 100 phacos, you've done 20 eyelid procedures, you've done 30 glaucoma lasers. I don't think there's this option in Medisite. Okay? So the only option you've got is to count them manually and then add it at the bottom, as a consolidation sheet, or use the iLogbook, which is again good in my opinion. Issue is that if you haven't got the exam yet and you're not a member, you have to apply for an affiliate membership and you pay money per year. So that gives you access to it and access to the 14 Fish. These two are not mandatory. So some people are just fed up. I don't want to use anything. I don't want to pay any money. And they're not paying anything, and that's fine. You don't have to be a member to apply for this. So, but at that point, you have to use the offline forms, and you have to use an offline logbook. Okay, I'm sure there are others online. There's lots of colleges out there that use logbooks and stuff. So just use anyone. It doesn't matter. Okay, fine. Does the cataract audit have to be exactly 50, or can it be more? For sure, you can add more. Especially if you haven't got the 50 consecutive cases, which it was the issue with me. I had to involve, I think, 107 cases, consecutive ones, and then I've written down in the methodology that we had to exclude the cases in between that do not have data. And then at the end, I ended up with the 50 that are required, which is fine, and it was okay. So don't feel too overwhelmed about this. That's fine. It's not a big deal. But obviously, ideally, if you do work at a trust that you've got all the post-ops, just get the 50 consecutive ones. In the past, in the past 3 years, I think. They have to be new, not old, and then to generate the audit, again, comparing it to the NOD data, the National Ophthalmology Database for cataract, vision, post-op refraction, and obviously complications. Basically, PCR. If you obviously do not include the rubbish cases that you've done with lots of PCRs. Ideally, you want to avoid them. But if you do, it's not a big deal. Let's say if you've got 1 PCR or 2 PCRs, it's not a big deal, okay? Because you will submit a logbook of complications, okay? And by the way, the consecutive 50 cases is not mandatory for level 3, okay? But my knowledge is that the continuous complication log is mandatory, okay? I know that this question was asked before, and I think Prashab, he put a screenshot from the SSG, and I think that's a bit vague, and a bit misleading on the SSG, because in the Excel file, it does say in the level 3 cataract that you still need the continuous complication log, which makes sense because they want to know that you're learning from your complications, and it's not something that you need to, get extra evidence for or whatever. This is something you should already be writing down as you are operating. So it's just basically a list of the complications that happened. What did you learn from it? What could be better? Something like that. You can even make up complications, by the way. If you're the best surgeon out there and you've got no complications, which I doubt, then you make them up and just write a scenario and then how we manage it. But the continuous cataract audit, on the other hand, the 50 cases, that's not mandatory for level 3. That's only for level 4, okay? Which is another advantage for the new curriculum. Okay, a very general question: how to organize and collate evidence. Now, again, for those who are still starting the pathway, don't want you to get overwhelmed. Obviously, there's lots of evidence, as you can see. The best thing you can do for yourself is to be organized. So you need a big folder on your computer, call it CESR. Again, have another copy on your flash drive, for example, CESR. And then inside the folder, you're going to put different folders according to each hospital, okay? And then inside each hospital, you're going to put different folders for each specialty. And then inside each specialty, you're going to put different folders, one of them called WBAs, another one called logbooks, a third one called letters, for example, courses. So the more organized you are, the better, because at the end, all you need to do is, once you're happy that you've got everything, you just go into that folder, whichever that is, and then select all and merge. And that file will be called glaucoma, let's say Newcastle Hospital, glaucoma CPDs from 24 to 25. So that's the name of the file. That's how you're going to organize your files and upload it at the end. So for those who spent already the effort in organizing the evidence per hospital, you definitely need to organize it per specialty as well. Because for sure, everyone who's submitting, and I'm sure everyone will agree, whoever submitted out there, the GMC comes back saying, no, please, this evidence is not accepted because it's not, organized or not submitted as per the SSG, and that needs to be per specialty. And you'll be very furious because you've spent all the effort and they want you to repeat everything and start from scratch and reorganize the evidence, which takes lots of effort and it will just mess everything up. So from day one, start doing it as explaining just per specialty, so per hospital and per specialty, okay? When the time comes later on, before you actually start uploading things on the application on the GMC website, you need to do another folder, all right? Call it the application folder, so CESR application. And then inside the application, you're going to put the folders of the application, so domains. So domain 1, we're talking about the new curriculum, patient management. And then domain 2, health and promotion or whatever it's called. 3 would be education. 4 would be safety. Whatever domains they are there, you're going to put the folders, and then inside of them, you're going to put whatever evidence that you need from your original folder. So you're ready to put everything in the right place. Okay, but that's the last step, so don't worry about that now. That's the final step, so you don't get overwhelmed. Okay. So I hope again that answered the question, but it's not as easy as it sounds. But that's the general sort of approach, in my opinion. In okay, how to redact from patient letters? Adobe. Okay, that would be my suggestion. Adobe Pro, not the normal Adobe. Adobe is not paid for. You have to pay for it, subscription, and that enables you to redact and to merge files and to edit and stuff. Because again, I think someone else asked about which software to use. Has to be Adobe. Okay, and I think the GMC advised it. So I haven't got any financial interest, by the way. I don't have any. I'm not a shareholder in Adobe. I wish, but that would be a good way to use it. If you want to use anything else, that's fine. Just make sure that you're not on Word, for example, just putting a text box on top of the patient data, because they will come back to you saying, "Oh, we've actually removed that box and we could see everything." So make sure that it's redacted properly. Okay. Some people sort of, if it's on paper, just black pen and then scan it, which is fine. So see what you can do. But I think the easiest and the most guaranteed way would be the Adobe Pro. And again, regarding redaction, you need to remove the patient name for sure. You need to remove their data, their hospital number, their NHS number. You can keep the date of birth for sure. Okay. If it's an age, that's fine as well, and gender. Okay, that gender is fine as well. That's fine. Address, you definitely need to remove. GP details is fine as well. You can keep it. Colleague details is okay if it's not a complaint. Yeah, you don't write a letter saying, "Dear Mustafa, I'm really sorry about your experience. This other surgeon, Mr. X, has treated you horribly. I'm sorry about that." So in that case, you have to remove their name. Yeah. But if it's a thank you letter or if it's a good management or whatever, then you can keep their name. That's fine, right? Fine. In CV employment history, since graduation or only past 5-7 years. So in the CV, you write everything. Yeah. So from the day you stepped out of medical school, right? Internship, house officer job, fellowship, foundation year, whatever, you write it from there, because they've already got that data. Because when you registered as a primary medical qualification, they've got this data. So you don't need to submit any evidence for that, just in the CV. Okay. However, in your employment history, in your in your last 5-7 years in the application, then you need to submit evidence of that. So let's say, you've worked in this hospital, you want to get some evidence from it, that's fine. You don't need to submit evidence from graduation, right? It's only in the CV. The CV, you need to submit or write down your experience in total. If you've got a gap more than 28 days, they will send you a form saying, can't even remember the name of the form. Please fill out this form to tell us why you've had that gap. There could be different reasons, marriage, maternity, studying, sabbatical, whatever, doesn't matter. Holiday, who cares? Then you just write down that you've spent something useful in that time. Just say I was preparing for my exams or something. It doesn't matter. Okay. Do we need 3 MSF and patient feedback as well? You need 2 MSF, not 3, so at least 2. Obviously, if you get 3 or 4, great. Yeah. But at least 2, and it doesn't necessarily have to be the MSF. Yeah. So MSF is the one from the college. You can use it, that's fine, but there are local trust ones. Yeah. So it's called 360 or annual feedback or whatever. So different platforms use different names. It's the same concept. It's I think at least 15 colleagues, I believe, and get them different people. So consultants, nursing, HCAs, trainees, optoms, different people, admin, different people to comment on your practice. So you need 2 of those, and ideally a patient feedback. I think that's important as well, but maybe 1. I think that's fine as well. So get 1 again, just to show that patients like you, and that and ideally that there is a proper way of doing it. You cannot hand over a patient feedback to ask them to fill it now in front of you, because it should be anonymous. So ideally you should print off, let's say, 20 of them and hand it over to the nurse outside, and she randomly, gives it to them. And ideally, again, after the consultation, yeah, without you knowing who that person is, without you knowing who filled it out, who did not, just to make it anonymous and unbiased as possible, yeah. But obviously, no one does that. Everyone will keep this stack of sheets in front of them and hand it over to the patient when they're done. And please, Mr. X, when you're done, please hand it over to the front desk or with the nurse outside. Yeah, that's the proper way to do it. Some people use it electronically. Not many patients know how to use these things, but I think on paper is fine. Do we still link 3 LOs in each form? We've discussed it. I don't think that's the case anymore, because again, let me show you the outcomes. So this is the Excel file I'm talking about. Yeah, so that's your main go-to file. And again, if you go, let's say, plastics, these are the outcomes. Yeah, so CRS1, DOPS, whatever that is, OSATs. These are the outcomes now. Okay, not those ones. If you go to the website, and I'll show you how to get to this website. These outcomes are not for you to sign off. Yeah, so if you go patient management, oculoplastics, level 1, for example, see those outcomes? Very vague. Yeah, work effectively with patients. So, it's not specific. It's not a specific outcome to tick off with a particular form. Yeah, if you click on it, it gives you descriptors. Yeah, and it gives you how would you assess it. So, for example, this one is just by the EPA. Yeah, so you don't need an extra form out there to associate it to. Yeah, and there are, again, related learning outcomes to it. It's just very vague. It's very confusing. So avoid them. Okay, so this first tab basically is not for you. Okay, so do not waste your time much. Obviously, the patient management, that's the bulk. These are all the SIAs. From this point onwards, all of these are signed off by the GSAT form. Okay, GSAT. I think that's the general. It's a weird sort of abbreviation. GSAT. There are 4 forms of it. 1, 2, 3, 4. You only need level 4. Okay, and 4 of those. So you need 4 level 4s GSATs. Okay, different people. That's to tick off all of these boxes. Okay, and if you click any of those, it will tell you GSAT. Okay, and inside that form, you again will see all of these domains, and then how would you prove your competency in education and training, for example. And then the same rule applies. You're going to write down, oh, I've done this course, I've got letters, I've got testimonials, I've got this CBD, I've got this and that. Then you'll tick off this box. Yeah. So a GSAT is very similar to the EPA, but it's not covering clinical stuff. It's covering the non-clinical things, which is not huge. Okay, so if you think about it, it's not many forms at all. Okay, you just need to make sure that you've ticked off all the points inside of these forms. Okay, fine. Okay, so that's the learning outcomes. These are the assessment tools. Okay, so that's the button you're going to press to find all of the forms. Okay, so as you can see there, these are the EPA. So 1 and 2. Ignore that column at the end. Okay, so this is for trainees, not for us. So you just need 1 of each. That's it. Anyone can sign it. Doesn't need to be a specific consultant. Anyone, because everyone can do general ophthalmology. Obviously, you need the level 3s. Okay, and by the way, if you're doing level 4, you still need the level 3. Okay, so try not to take shortcuts. You still need the level 3. So fulfill level 3. Okay, so all of these are necessary, and then only 2 of those. Pick whichever is easy for you and which you like. MAR we're going to cover later, which is not necessary, by the way. GSATs, that's the one I'm talking about. That's the level 4. So if you open this one, I hope it opens. This one. Same applies, level 4, and then all of the domains. Yeah. Let's say again, leadership. trainee self-assessment is like a reflective sort of, oh, I've done this course, I've benefited a lot. Please see reflection page 5. Yeah, reflective diary, page 5. And then supervisor meets expectations. He's shown this, he's done that. I'm happy that he can do this, that sort of thing. And the same applies for everything else. So you need 4 of those. And if you technically fill those and satisfy the assessor that you've submitted evidence to prove those points, that should be enough. Okay, so technically easy, not that tricky. Fine. Where was I? We'll go back to the Excel file in a bit. Okay. Fine. What else did we? Can LOs be evidence with clinical letters? In the old curriculum, possible. Okay. I'm not sure if you've watched the previous CESR chats videos, but someone used only his patient letters to prove associations to outcomes. Yeah. So he did not use many forms, so not many CBDs and no logbook, for example, but submitted lots of letters, very good letters, very detailed, to maybe associate it to, let's say, fluorescein angiography. Yeah. But then in the letter he mentioned, I've done this, I've assessed this. The fluorescein showed this, the arm to neck time is this, and it showed delay, it showed leakage, we've done this, we've done that. Who does that, in the letter? No one. So do not rely on your rubbish letters to associate. It's not enough to say, I've done fluorescein. It's not enough at all. Okay, so you need to write down a bit more in detail. No one writes all of these details in patient letters, because it will go to the patient. So if you want to, that's fine, but just be careful of what you're writing down, and do not rely too much on the letters, because, as I've said before, it's weaker evidence. Compare someone who's got lots of forms signed off by other people saying how good they are versus someone else who is saying, I've done that, I've done this, and I'm great, I'm capable of doing that. Who knows? Yeah, so always aim to do more forms. That's the best and strongest evidence. Okay. Fine. But in the new curriculum, not really. Okay, as we said, there's no outcomes to to associate it to. If you want to, let's say, again, for example, in the Excel file, let's say CRS. Yeah. So this, this specifically, there is no star next to it. So basically, you cannot uh, uh, use alternative evidence. Yeah. If you look at this sort of box, let's say something like that, DOPS, Botox to induce doses. Ideally, you need 2 DOPs, okay? But it's a bit more flexible now, so they've given you the option that you could possibly submit a surgical note of another case. Maybe you've done Botox for another case, you haven't got the DOPs signed, but you've got actual Medicite letter, for example. Then you can use that testimonial letter. Oh, I've seen Mr. X do it, and he's very good. That's a testimonial letter, so you don't necessarily need a DOPs in that case. But again, my suggestion is do more forms. Okay, forms are excellent. These are the strongest evidence. So, for example, CRS. So it's very clear that there's no star next to it. So that means that you need to do 2 of those. Okay. Another question again came up. So it's CRS1 is here, but then another one is here as well. So do I need actually 4 of those? I don't think so. Okay, that's my opinion. Take it or leave it. I don't know. It's a vague question. We don't know. In the old curriculum, it was very clear. You don't need 4 of them. But in the new one, I think it's a bit vague. I think 2 would be enough. So for plastics, for example, you need 2 of those. That's it. But maybe in the second one, which is the level 4 one, try and get a bigger case. A more advanced case, complex case. And maybe label it, just level 4 plastics or something, just to show that's more complex. Okay. But yeah, basically, there are some things that you can associate it to letters. Okay, and it gives you a list there. Reports, histories, clinics, testimonials, whatever. So there are some flexibilities. Okay. So if you follow this Excel file, that would be great. I don't think you need any other Excel file, in my opinion. Okay. Who would be the verifier for a cadaveric course? Again, a very good question. Obviously, you don't need a verifier from that particular hospital, okay? Because it's not considered as clinical practice, all right? My suggestion is to put it in the verifier form during that period, yeah? So I work in Newcastle, and I've went off to London to do a cadaveric course, so I'll still put it in the Newcastle verifier form, okay? That's what worked for me and for many others. I don't believe anyone has asked, all of the GMC advisors to not ask anyone to provide a separate verifier form for that particular course. Because the same rule applies if you've done a course in the Royal College, for example, if you've done a course in overseas. So do you actually need a verifier for that particular course? Not really. Yeah. But again, if it's overseas, that's a bit debatable. Okay, so we discussed this before. If you're doing stuff overseas, which is perfectly normal, you try and get as much evidence as you can. Obviously, logbooks and a letter from the consultant, and maybe a certificate of the course that you've done or the cases that you've done, and then put them in the verifier form. So maybe courses overseas is a bit different. Okay. But in the UK, you don't necessarily need a verifier form from that particular course. Okay. Can we use old paper forms for the new pathway? Definitely yes. Okay, so there is a mix and match, but there will be some gray zones that we're not sure if it's already fulfilled by the old one, or do you need to submit extra evidence with the new curriculum? And as always, I've been advising that you should do more rather than less, just to be on the safer side. Continuous catheter complications log versus 50 consecutive cases audit. We've covered this. So complications log, mandatory for everyone. I won't call it mandatory, yeah, but very advisable. Okay, let's call it advisable, suggested, because it's a reflective log, yeah. So just to show that you're learning from your cases. But certainly the 50 consecutive cases, that's not mandatory for level 3. It is mandatory for level 4 cataract. Okay. Leadership courses. There is a course that I figured at some point. So the name of the course is Future Learn. No, not that one. This one is Train the Trainer. Yeah, so this one is a different one. This one is again useful, and I think it's for free. I'm not sure that £40 extra, what does it do exactly? But consider this one, okay, if you don't want to do the college one. This works, okay? The management is the Edward Jenner one course. That's the management one. It's big. It's there are levels for it as well. So again, don't ask me which level is needed, but I guess if you do just one level is fine. It's again about the reflection. So if you do any course and then you reflect on it and see how that sort of applies to your practice and how you've improved in your practice, that should be enough. I per se, I did not submit a specific leadership course because I was responsible for a long time for delivering courses and training and education. So I used that to fulfill this requirement. Yeah. As a leader or as a tutor, for example, all of these evidence work. But if you don't have any of that, then ideally you should do a course. Obviously, there's the ELFH one as well. So I'm sure everyone has. Whoops, what's that? Crap. Hold on. ELFH. This one. Again, there's lots of courses, and I think it's still working. By the way, someone mentioned it will shut down. I don't know why, but it is still working. So join it, and then you'll find a few courses there for you to use. Okay, definitely useful as well. Fine. And these courses are mandatory, by the way. Yeah, so again, let me show you the last course would be the GCP. I'm sure, again, everyone has heard about it. And IHR is the one. And it's free for all NHS staff. So do this one. again, just to tick off the box for research and good clinical practice and research and stuff. So get this done. You'll get a certificate, and always do a reflection. Okay, so any of these courses, always do a reflective piece on it, just to support your evidence. Okay. Are EPAs necessary? Yes, I think they are, but they're not mandatory. Okay, so I think definitely do them if you can. If you don't do them, that would be very risky, in my opinion. How to record CPD points. So there is an option on 14 Fish that you can add your CPD points if you wish, just to keep track. I think it's rubbish. You don't need to do it. You can just have your own diary. Okay, so just a Word document with a table. So the date, and then obviously the year, date, month, or whatever, and then the name of the course or conference or whatever you've attended. And if you want to be a bit more specific, there is a type of CPD as well. Is it A, B, and C, I think. So external teaching, internal teaching, self-learning. There's a few categories there, and you'll find all of these guidelines on the GMC and the college. So you can add the category as well, and the points. So points meaning hours. So 1 hour equal 1 point, even if you don't get a certificate mentioning 6 hours. Yeah. So for example, this sort of 1 hour, 2 hours that we've done now, this is a CPD point or 2. But am I going to give you a CPD certificate? No. Yeah. But you still record it as an online or self-learning sort of thing to help with your application. Yeah. So call it, I don't know, online webinar for CESR or something. Doesn't matter. Yeah. So you don't necessarily have to have actually CPD points registered to put it in your CPD diary. So you will need that diary as I explained in the table for your CV. Okay. That's the GMC guidelines. In addition, you will have your own separate CPD file with all the certificates after each other. Yeah, so all certificates, all attendance, all courses that you've done, you'll put them there, and then that will be used again in a specific part in the application. What was I? Patient identifiable data, we've covered that. And what sort of data can be removed or should be removed. What standard should be followed in the cataract audit? So these are the NOD, yeah, so National Ophthalmology Database. So follow those. Okay, so PCR is 0.8% or whatever. Try to stick to that, and the refractive outcomes and the vision, pre and post. Are CSRs mandatory? Yes, I think they are mandatory as well. If you're going to the old one, I think they are mandatory. If not, then just get a letter. But ideally, I've done both. Just always do more. Where to attach MSF, and do they fulfill any learning outcome? So the MSFs would be a part of the feedback, and they will have their own again part in the application, and you can link it in the EPA. Yeah, so not the EPA, sorry, the GSAT. Yeah, the GSAT again. There is a part about feedback, yeah, and communication and teamwork, whatever. So you will put it there. But in the application, there is a place where you upload your feedback and your annual assessment, that sort of thing. Whether it's appraisal or ARCP, whatever. I would suggest, by the way, to open an application as well, just to play with it, give it a go, see what it looks like, what does it entail, and you can always close it, open another one. I think it's open for a whole year, so you can play with it, whether it's the old one or the new one. It will ask you. So the old one is the 2016, the new one is the 2024. Okay, just pick whichever and see what the domains are and how to upload things and stuff if you wish. It's up to you. What are the verifier proformas? It's a very good question. So let me show you verifier. Let's use this one, for example. Share the screen again. So this one. It's an example of a verified proforma I've used from Bournemouth Hospital. And I think it's still the same now. I don't think it has changed from the GMC website. Basically a table where you put all of the documents from that hospital. Okay. So I've put appraisal, I've put CPDs, I've put all the forms, the type of the file, the date, and number of pages is extremely important as well. Why is that? Because they want to make sure that the verifier is looking at your files and you're not sneaking in more pages that are not there. Okay, so I'm your verifier. I've looked at the verifier form. Oh, you've put CVDs 18 pages. Oh, but actually the evidence has got 20 pages. So you've sneaked in 2 more pages without me knowing. Yeah, so they want to make sure it's exactly the same amount of pages. Yeah, so very important to stick to that. And more importantly, the name of the file is very important as well. So you're going to submit it and upload it as a specific name, copy paste it here. Okay, do not change the name at all. And then at the end, they're going to sign, and that's it. Yeah, so that's your verifier form. You need one from each hospital. Okay, and it can be any consultant. Someone even said it can be not a consultant, but again, it's a bit sort of risky. I'd suggest a consultant if possible. Where were we? Would Calesians count as plastics procedures? Yes, but do not put 30 Calesians. Yeah, maybe put 5. Maximum. Do not put more. Okay, that will not be included. They are looking for more complex things like lumps and bumps, excisions, simple excisions, electrolysis, maybe 3-snip procedure, everting sutures, eyelid repair, entropion, ectropion. You don't need to do the full case. Yeah, you can do a part of it that would be considered as performed supervised. Assisting is a bit different. So there's a very thin line between both. Assisting, basically, let's say you're just doing suction, for example. But if you're taking big steps in the operation, that would be performed supervised. Okay, but I'm sure everyone would agree that there is a very thin line. You don't know exactly, should I put it here or there. You need to ask yourself, have I taken most of the steps in the surgery or not? And if your consultant is happy, that's fine. How to show in level 4 evidence of training to others. So we've mentioned that before. So supervising juniors, so SJ in your logbook, supervise the junior, and I believe needs to be 20 still, I think, in level 4. You can get letters from them as well, like a testimonial, just thank you, Mr. Dovidor, thank you for helping me out in the past rotation. I've learned this, you've learned that, I've changed my practice, blah, blah, blah. It will be mentioned in your MSF as well, that you're a good learner, you're a good teacher and educator. What I did as well is I signed trainees for some stuff, like CPDs or OSATs, DOPS, and then that form gets sent to them, obviously, to use in their application. But then I asked them to please send it back, because you don't get a copy yourself. So they will send it back to you so you can use it in your application. Again, that will prove, especially in this case, level 4, for cataract, for example, you need an OSATs. You've signed a trainee off for the OSATs, then you'll need it in your application to show that you've trained them, but obviously remove their name. Okay, your name is fine, but remove their name. Who can sign off forms? I suggest, again, EPA would be consultant. CBD, I think, again, it should be a consultant, although that is a bit of a flexibility. It can be a specialist, for example. Do not get fellows, do not get trainees to sign CBDs, just doesn't make sense. OSATs, again, ideally consultants or fellows. Yeah, so again, a senior fellow who's about to be a consultant, that's fine. DOPS are a bit more flexible. You can get trainees, maybe ST4 and above, to sign some DOPS off. That's fine. It's not a big deal. But the best thing to do is get more senior people and different people. That's the whole thing, just to show that everyone is agreeing that you are a competent person. Okay. Are logbooks still needed or necessary? Yes. Okay. I think logbooks are a very good way of showing the different cases that you've seen and managed. There's no numbers. Okay, so do not keep asking about numbers. There's no specific numbers, and it's very obvious in the guidelines or the guidance. My suggestion is, again, this is a rough figure from my head. If you're going level 3, maybe aim for about 30, 40 cases, maybe. It's about the quality, not the quantity. Yeah, so quality of the case. If you're doing level 4 in that specialty, then aim for more, maybe 60, for example. Yeah. Again, quality. It's all about quality. Another option is to do case histories. Yeah. So it's like a case logbook, but with a bit more detail about the case. So as if you're presenting it in a conference, for example. So this patient is, presented with this and this history, ocular history, medical history, examination findings in detail, investigation findings, treatment, a reflection about the case. I've read this paper about, how to treat keratoconus, for example, and I've reflected on it, and that's how I'm going to change my practice. So like a one-page document of that case. So it would be a good idea to show again the depth of involvement in that case, especially if it's in your specialty. Yeah. So if you're doing level 4 in that specialty, you want to show that you've actually, um, uh, been involved in the cases. And again, to serve your triangulation of evidence. Triangulation, I'm sure everyone has heard that term before. Just multiple evidence to serve that particular patient, yeah, to prove that you've actually seen them. So for example, one evidence would be the logbook or / case history. The other evidence would be the CBD. The third one would be the patient letter, for example. Yeah. So that would be triangulation. So try and do as much triangulation as you can. You don't need to do that for all cases. Okay, I know that question will come. Do I actually need to triangulate all evidence? No, but the more you do it, the better. Just serves to strengthen the application. And I think that it was mentioned somewhere that for level 4 you'd aim for 20 patient letters. Okay, so I think that was mentioned in the Excel file. So aim to do that. So if you're level 4, get 20 patient letters, and then out of those, let's say, get 10 CBDs. Yeah. So out of these 20 letters, choose the best cases. Yeah, and write the CBDs for them. Yeah. Again, I'd say 10 CBDs for level 4. If you're doing level 3, maybe 5. I think that's enough. And again, no specific numbers. I hope that's clear enough. Is it mandatory to get both level 3 and 4? Yes. Okay, so do not jump to level 4. It's level 3, done, and level 4. Can the same consultant sign both level 3 and 4? Yes, for sure. Obviously, at different times. It doesn't make sense me signing you off for level 3 today and then next week for level 4. It doesn't make sense at all. So try and separate the timings. Another very common question that gets asked is retrospective evidence. I think it will be asked later. Retrospective evidence. So we all agree that it doesn't make sense for me to sign you off for a DOPS, for example, that you've done a year ago. Doesn't make sense. Okay. So it's always think the practical stuff needs to be retrospective. Sorry, needs to be prospective. Okay. So has to be recent, maybe in the past week, 2, roughly. Obviously, if the consultant is happy to sign it, older than that, it's at their discretion. But if the college notices that it just the dates don't match or something is not right with the dates, they will not accept it. Okay, they will just say we're not satisfied. We've noticed that some of the evidence is retrospective. It's not accepted. Something like that. So try and aim to do these things prospective. And luckily, the forms are not many now, so it should be easy in the new curriculum. CBDs, on the other hand, can be very flexible. Okay, we can discuss a CBD now, and I can sign off CBDs online, by the way. Yeah, so the trainees sign off CBDs in conferences or in teaching, regional teaching, for example. So that's fine. It doesn't need to be my case. I don't need to have seen the case. It's just a discussion. Yeah, so CBDs are a bit flexible. I had to sit with 2 consultants and sign off 10 CBDs each in one go, like 2 hours. It's like an exam, so we had a chat and then they were happy to sign us off. Yeah. So that's flexible. So avoid retrospective evidence, especially, it's a very big tip there. Let's say you want to sign off something old, yeah, before the new curriculum sets in. So you remember that the new curriculum started in, I believe, June 24. So all of these new forms are June 24 onwards. Do not put a date before that because actually these forms were not there. Yeah. So if you want to put, let's say, a CBD retrospective, which is fine, it's not a big deal. Do not use the new CBD form because it will be very obvious that you're faking the data. Yeah, so that's my huge tip out there. Do not use retrospective evidence. If you are going to use it, if you want to get old data, you have to use the old forms. Yeah, putting the new forms in will not work. Okay, but as a general rule, prospective. Okay, they want someone who's doing current prospective evidence. They're practicing, especially if it's something practical, which makes sense. Okay. Okay. Where are we? Is it too much to show a copy of the patient's visual field along with the letter? Yes. Okay. Do not add investigations. They wouldn't care. Okay? They don't want to see investigations. Fields, scans, whatever. Do not do that. It's just a waste of time and effort. Do retinopexies count as retinal lasers or all need to be PRPs? Definitely. Retinopexies are, in my opinion, they're even more important than PRPs. Yeah. For someone who's not doing retina, they need to do retinopexies as an urgent thing. So get a mix. Okay, a mix of pexies and PRPs, maybe macular lasers if possible. Why not? Is a contact lens clinic attendance mandatory? No, it's not mandatory at all. But again, this will be supplementary evidence. Okay, so it might help a bit, especially if you want to link it to something specific. Let's say again, a DOPS for a BCL, removal, for example, and you don't want to do DOPS, so then do one DOPS, and then the other form would be a testimonial again from the optom doing that clinic, saying that I've seen them do that. We've discussed different cases. They're aware of complications. They're aware of this and that. That's it. But obviously, for the BCL, you need to do it yourself. Okay, DOPS is a direct observation of procedural skills. You need to do it yourself. Observing it is not enough. It's a practical thing. Can I collect evidence retrospectively? My suggestion, no. Okay, try and keep it prospective. That would be my advice. Learning outcomes. Oh, for learning outcomes like keeping clinical records, IT, and managing referrals, can they all be associated in one testimonial or have to be separate? So that person is asking about the old curriculum. Okay, this one is not in the new one. In the old one, yes, you can collect these evidence in one form or a testimonial letter. That's fine. But as usually, I'll suggest a form. So let's say CBD. CBD mentioned that, oh, I've seen him record the clinic well. He's got very good IT skills. He can manage referrals well, blah, blah, blah. If you can justify writing it in that form, if you write in what especially was good for that candidate, then to write it there. And then you can associate these outcomes. You have to justify why you're associating the outcomes. Okay. For the new one, you don't need to do much of that because in the GSAT, there will be a box saying IT, for example, or referrals, for example. Then you need to submit evidence why you think you can do that because, I've got this testimonial letter, I've got this email thread, you get a screenshot of the emails, discussion with another team member or another specialty. Then you can tick off this box, for example. Do I need Botox to induce ptosis for eye protection? How about Botox for squints? So I don't believe, let's actually see in plastics. I don't think that you need, I'm not entirely sure. Hold on. Plastics. Yes, you do. I think you do. See that? This bit. Not sure if you guys can see it or not. So for plastics level 3, you do need Botox for induction of ptosis. But again, it's a bit flexible. So there are a few options they can do, not necessarily a DOPS. So again, if you attend a clinic with one of the nurses or something, that would help, which is a bit annoying, I have to say, because the old curriculum, you did not specifically need it for ptosis, yeah? And just doing it for hemifacial spasm is enough. You don't need it for squints, I think. Let's again go, as you can see, we're still learning about squints. So see that? Botox injections. A DOPS for Botox is required for level 3 only or a CBD. Reflective notes. Okay, so again, they've put it in red, meaning that it's not essential. Okay, you can do a CBD or just a reflection or a testimonial. That's fine, which makes sense to be although level 3 you don't require knowing how to do a Botox for a muscle. It doesn't make sense. But obviously in level 4 you would. Okay, so I can summarize. In plastics, you need it to induce ptosis. Okay, maybe get one DOPS, maybe another testimonial or logbook or whatever. And then in squint, you will need it only for level 4, okay, not in level 3. All right. I hope that simplifies things. How many audits? Minimum 3. One of them has to be a full cycle. The same rule applies. Okay. The full cycle doesn't necessarily have to be from A to Z. You can be involved in a stage of the audit, ideally the last stage, obviously, to show that you can know how to do the re-audit and complete the cycle. But you don't necessarily have to do the whole thing from A to Z. Okay, so again, don't be overwhelmed of I have to be leader or I have to do this whole thing. Yes, you need to submit evidence showing that you've been involved in many of the stages, but at least one of them has to be like that. It has to be that you're the main person. Yeah, but the others, maybe the other two, you can maybe collect the evidence. You can just get the certificate, for example. You can present it. You can do the poster with your name there. Just one step should be fine. Okay, maybe the presentation or maybe a screenshot of the minutes, the meeting, the audit meeting, for example, and you're presenting it. That should be enough. And luckily, again, if you're not doing level 4, you don't need the extra cataract audit that we've discussed, the 50 consecutive cases. Okay. MSFs need to be anonymized. Yes. Not even a signature. Yes. Okay. So no identifiable data at all with MSFs. If you're going to print it off, just leave it blank. They will fill it out. No names, nothing. All right. That's the whole point. And someone will come back to me saying, "Oh, I'm going to fake it. I'm going to get my family to write it down for me." That's between you and your subconscious, I think. Any examples on disease risk reduction? I think that was mentioned in the group as well. Yes. So, I mean, you can mention also AMD and smoking, thyroid and smoking, maybe pregnancy and glaucoma drops, for example. There are lots of maybe hydroxychloroquine, toxicity, and then a CBD about, that you've discussed with the patient that you need to stop that medication, for example. Loads of examples out there. Uh, Overseas qualifications and authentication. That's a very good question. I think that you don't necessarily need to put any overseas qualification, by the way, if you've got your FRC off, right? It's just an extra effort, extra money, extra headache. I don't think you need it at all. I know that you will think it's a waste of time, it's a waste of effort. Yeah, I want to use it. I've spent all of this effort and money for it. I want to show it in my application. That's fine, but it's not mandatory. Okay. What you need to do is, it was very clear in the guidance. So either you get it stamped and signed, obviously the translated certificate or syllabus from your from your um, from your institution back home, and that should be enough. The other option, if it's not stamped, then you get it translated and then notarized here in the UK. So a solicitor, basically, they're just going to look at the copy of the certificate and the copy of the syllabus, make sure it's real and authentic, and then stamp it and sign, and that's it. That's notarized. It's cheap. It's not very expensive. And then you have to send it off as a document by the post to the college so they can see the document and the stamp. Is it necessary? No. I think it's a waste of time. That would be my opinion. Okay. But that being said, I sent it myself. Okay, so I did it myself. But everyone who did it always tells the next generation is that it's not needed. Yeah. So do I need my primary medical qualification as well? No, because they've already got it. Okay, so do not. Although it's mentioned in the application there, yeah, you don't need it. If you put it, they will ask you to remove it. It's not necessary because they've already got it from your original registration. If you don't have an original registration, then that might be the case that you would need it. Okay, so again, it needs to be confirmed and I think verified by Epic. I believe there is a way to do it. Do we need secondary? Oh, do we need to do biometries? Yes, I think in cataracts you still need biometry, DOPS. I don't think you need two. Just check the Excel file again. You need one, and then the other one will be flexible. You can get another form or whatever, but you still need it. Yeah, biometries are important. I did one optical one, and the other one was an A scan. So again, just to show variability. Maybe a CBD, just to discuss. Oh, I've discussed with him the different formulae. He's aware of the college guidance. This patient required a specific lens, whatever. Do we need secondary IOLs for level 4 cataracts? I don't think so at all. No. Level 4 cataracts is mainly to show complicated cases, complex cases that you know how to manage them surgically and how you can train others. That's the main thing about level 4. And the numbers, obviously, you need more numbers. But I don't think you need a secondary IOL at all, no. Maybe in VR, I'm not sure actually. I don't think even in VR they request, how to do scleral fixated IOLs, for example. I'm not entirely sure, to be honest. You need to check that yourself. How about rupture globes? I think rupture globes are important. I think, again, let's check. I think in emergency, you will need this emergency here. I think urgent ophthalmology. This one, urgent eye care, should mention rupture globes. Where is it? Theater there. Yeah. So ocular reflex trauma, OSATs, you need two. But for example, it's not mentioned in level 3. So do you actually need it in level 3? No. So again, it might be a good option for those who want to do level 3 and, because they don't have access to rupture globes, then they just have to do it level 3, urgent eye care. Okay. Unlike the old one, you need to do all of them. So no levels. So here, there's another advantage, I think. Okay. What if there is no opportunity? Would simulation be okay? That's a good question. I don't think simulation would be appropriate for level 4. Very risky. Because this doesn't make sense. Level 4 means that you are about to become a consultant. Would you be happy to do your first rupture globe as a consultant? I'd definitely not be happy. It's you need to do it on patience, I think. It's common sense. Is that mentioned somewhere in the SSG? I don't think so. Yeah, but it's just weird. How would someone sign you off for level 4 if you haven't done it on any patient? Very risky. How many MAR forms are needed? 12 per specialty? Definitely not. So MAR is the multi-assessor report. These are not necessary at all. Okay, so MAR reports are, I think that person was referring to the EPA. Yeah. So definitely not 12 per specialty. You need the EPA, the 1 and 2, that's done. Level 3 for everything, and then 2 level 4s for the 2 specialties that you want. MAR forms are optional forms. We usually use them for the trainees to strengthen their knowledge or skills in a particular point. So let's say I'm training someone in glaucoma, and in their annual sort of educational supervisor report, I've mentioned that they're a bit weak on doing gonioscopy, for example. Then I'll ask them to do an MAR form, just to focus on gonioscopy. There is a list, again, similar form. Again, there's lots of boxes, generic ones. So one is clinical skills, another one is investigative, for example, another one is communication. So, and then you pick the specific box. So let's say in this case, skills, yeah. And then I'll write down, so the trainee will write down, I've done this, I've done that, I think I've learned this, I've reflected on this. Then in my comments, I write down, yes, now he's proved that he can do this skill by submitting this piece of evidence, for example. Yeah. So it's an extra form. It's not mandatory. If you've done everything and you're happy and you've covered everything, then you don't need the MIR forms at all. So MIR or MAR forms are not essential. if we train a junior doing IA and IOL, can that be counted in my FACO numbers? That's a very what's the word? It's a bit I don't know, debatable. I got this question before, I think. I certainly don't think that if you do the majority of the case, that's fine. Then you write it down as P, not as SJ. So if you've done your SJs, which is 20, I think, then you don't need to do any more. So any further SJ, just put it as performed, yeah, because you've done the most of the case. But let's say the trainee has done mainly everything and you just assisted them in one step, for example, then that's not your case. At that point, that would be him putting it as PS and you put it as SJ if you wish. But you don't need to put 200 SJ, yeah? Just the needed number, that's all. So there's, again, a very thin line between you doing the whole case or is it you, the assistant, again, in Medisite, and it always is an issue with the junior when it goes wrong. So they are afraid to put themselves as the main surgeon. They want you to put it as the main surgeon, and they are as the assistant. It wouldn't change things much. But I think very important in that case to put it in the notes. So let's say again, he's done it, and then you took over. That's important. Okay, so you put it as supervisor junior, but then you mention that you took over the case to manage the complication, and actually that's in your favor because again you're showing that you're managing complications. Okay, so so yeah, to answer your question, if the trainee is just doing IA and IOL, I think you put it in your logbook. Yes, that's fine. You put it as performed because you've done the majority of the case. Yeah. I think FACO. I think if the trainee does the FACO, then it's their case. Yeah. So, but see how you feel that in your head. Clinic logbook, does it need to include every case we did a CBD or DOPS on? No, but why not? So you've got a list of CBDs, so definitely put them in the logbook. Why not? It's the other way around. I mean, the question should be the other way around. Is every case in the logbook needs a CBD? Definitely not. Right? But as I said, the more triangulation you do, the better. So in the logbook at the end, last column, it'd be very nice for you to add a column, call it triangulation or call it WBA, for example, and then write down, please see glaucoma CBD number 5, for example, just to link it to that particular case. It's always nice to do that and highlight it, perhaps. Okay, what should we not miss when writing a CBD? So the summary of the case at the top, we discussed very short summary. The boxes that, good or very good or no concerns, they don't care about that. I don't think they will look at it at all. Obviously, they will look at it if there are concerns. Yeah. The main thing is the last bottom 2 boxes, just to write down that you've managed the case well. We've discussed this, we've discussed that, just to show the involvement in the case. Yeah. If there is any improvements, definitely write it down. You can reflect on it as well. If that consultant requires you to attend a course, you could possibly attend the course if you wish. Not mandatory, by the way, so you don't need to definitely follow what they're saying, but it's always good to show that you're improving. Yeah. So definitely do not miss writing up the last 2 boxes. What we do is we usually, write them ourselves, and then they will read it and edit it if necessary. Yeah. So it's fine to write the whole thing yourself, even if it's in your handwriting. Yeah. It doesn't matter because you are sitting with the consultant and you're filling it with them. Yeah. So that's fine. If you want to avoid that hassle, just write it electronically. Yeah. But it is okay to write it all in your own handwriting. That's fine. Okay. What evidence needed for audit? So again, different evidence. So either as the certificate, you can there's the audit team in the unit. You can apply for the audit or register it. Use that certificate. You can get the data. Obviously, redact the data. Presentation. Maybe the minutes when you're presenting the case. A poster. You're submitting it somewhere. Use that. So different evidence. Doesn't matter which. For old pathway, do we need testimonial from consultant or CSR or both? I think ideally both. Okay, so always aim for a letter from all consultants, ideally with a CSR. Sometimes the consultants are tough. Again, we've met all of these consultants. They don't have the time. And if you think they cannot do both, just get a CSR. I think that's the better one out of the two. Um, and similar now, the EPA. Yeah. So if you can get either a letter or a PA, definitely get an EPA. Yeah. So EPA, I think, is stronger. What app to use to write all learning outcome associations and to highlight them on the forms? Adobe wasn't useful. That is a shock. I think that person was using just the normal Adobe, not the Adobe Pro. So you need to subscribe to the Adobe Pro. That will enable you to edit and to add text boxes and to highlight and to redact and merge files. So subscribe to it. It's very good. I'm sure there are other apps out there, so it doesn't matter. Why submit more evidence shortly after submitting? 1 to 2 months later. That's a very good point. Remember, when you submit, the GMC comes back to you at least a month or two later. Yeah, during that time, you cannot even access the application. It's locked. Okay, once they assess and they advise on what points they need to be changed, then it unlocks again with just the points that is requested. So there's like a list of recommendations that needs to be adjusted. So you remove the file, you edit it, you upload it again, and so on. It did happen that people wanted to add more evidence, which is fine in a way that if the advisor is flexible, which is not always the case, by the way, if they think that, it's an extra page, why not? Especially if they recommend it. So they tell you, please submit an extra evidence of audit. Oh, yes, I've just done the presentation last week. I'm going to add that presentation, if that's okay. That's fine. But do not tell them that I'm going to add 200 pages worth of evidence, which I've just got last month. Doesn't make sense. So, and always, if you're going to add evidence, they would usually require you to get a new verified pro forma because you're adding evidence. Yeah. If you're removing stuff, that's fine. And it will happen that, if you submit too much evidence, they will come back to you saying useless. Why are you submitting 20 case letters? Maybe just 10 is enough in that specialty. So you can remove things, that's fine. But if you're adding evidence, likely they will ask you to sign another form. So to answer your question, yes, there is some flexibility, but to a minimum. Yeah, so you cannot rely on the advisor to allow you to add lots of evidence during that period. And it will be long, so 1 to 2 months, that's the locked period, and then they come back. And from that time, they give you a deadline, I think in 2 months or so, and that can be extended. If you need some more time to chase the verifiers or to do this or do that, they can extend the deadline. Okay? But my advice is do not rely on this. Do not extend anything, because just get everything done from first go as much as possible. Do your best from that aspect. Can you share reasons for application rejection from your experience or what was missing? So one of the common, I won't call it rejection, but let's say recommendations, is not, especially in the old one, is not following the rule of getting 2 DOPs or 2 OSATs for each outcome. Okay, so specifically those, it would not be enough to get 1 DOPS for ultrasound and then the other one is a magnificent course that you've taught on to show that you're competent. That will not work. Even if you're the best ultrasonographer out there, will not work. So you need 2 DOPs. Okay, it's a very common scenario. Again, similar to OSATs, same rule applies. I'd say that's one of the common things that comes back. The other thing is obviously that's mainly the GMC, not the college. The way you've organized the evidence. Okay, so the GMC comes back saying, please split it by hospital and by specialty. Okay, so that's why I'm saying I'm coming from the future, saying please organize it per specialty. Okay, very important. Other things, I don't even remember. I think the forms. Yeah, I think the main reason was forms. Okay, but as I was saying, that's the old one. Okay, the new one, obviously, we don't know yet, but that would be less of an issue because, as you can see, most of the requirements, there is flexibility. You can get another type of evidence to fulfill that outcome, other than a form. So I think that would not be the case anymore. How long does the process take on average? That's a very good question. So usually you submit 1 to 2 months, GMC comes back, and then give it a few more months, emails back and forth between you and the GMC, adjusting the application, making sure it's the best it can be before going to the college. Once they're happy that the verifier is signed and the assessor and the referees, then they will tell you, okay, now we're going to send it to the college. That's the best case scenario. Sometimes there is a waiting list, a queue, which is horrible. I know someone who's waited like 6 months between the GMC and the college. They're stuck in between. Why? Because they couldn't find an assessor who is available at the college. But nowadays it's getting better. I believe most of the people who are getting their applications accepted, it's not too bad. So 8 months and 9 months in total. That's great. Yeah. But others have taken longer. But on average, I think best case scenario, you're talking about 8 months. Worst would be obviously a year or more. Yeah. Once the GMC sends the application to the college, they've got a legal duty to reply within 3 months. Okay. Up to now, I don't believe anyone has faced that issue where they had to wait more than 3 months. Okay. So once they come back saying, "Oh, we're sending it now," so wait 3 months, you should get a decision by then. Let's say you get the decision accepted, great, congratulations. If not, then they will give you a whole year to submit the extra evidence, whichever that is. So there is a long time. It's not, and certainly you will still keep with the same pathway. Yeah. So if you've submitted through the old one, you will still be assessed through the old curriculum, not the new one, right? However, if in the review, which is the second time you submit, if you do not follow what they suggested and the evidence is still lacking, that's game over. You'll have to start from square one. At that point, will be the new curriculum. I hope that's clear enough. Fine. I have finished the questions I've got there. Let me go through the ones in the chat very quickly. We're nearly done. Okay. Is the typed name enough for signature? No need for handwriting? Yes. Okay, so people have definitely submitted some forms with no signature and it was accepted. Remember again, it all comes down to the verifier. So the verifier will know that this person has actually signed the form with their name. And if they're not sure, they will get in touch with that person. Have you actually, I can see your name there. Have you actually signed that form for Mustafa or is he faking it? And they will reply saying, yes, I did. So you don't necessarily have to have their signature by hand. Recommended software bundle for the whole process, please. I'm not sure what you mean, but I think you mean Adobe. Yeah, so that's the software that you're going to. So Walid is asking, Walid Ian, I'm not sure if you're with us, but I believe you're referring to the PDF sort of software would be Adobe. Okay, so Adobe Pro. Obviously, you'll need Word, you'll need PowerPoint, you'll need Excel. All of this is very important software that you need. Do we need to provide letters for CBD submitted? Ideally, yes. As I've said, try and triangulate your evidence and submit patient letters if possible and link them to the CBDs. Okay, so if you can, that would be the best thing to do. But again, not necessary. Fed is asking regarding EPA 1 and 2. Now they are saying just to have consultant sign them. Is that even without evidence? Yes. Which is, I think it's too good to be true, I think. But yes, that's the case, is if your consultant sits with you and they're happy that you can do all of these skills, that's fine, which is weird, okay? And I think, again, I'm coming from the future, lots of people will complain about that. And it might disappear at some point to try and make use of it quickly, yeah? Because my consultant is not supportive. My consultant is very strict, and they're not supportive. They want to see me do all of these skills, and that was the reason my application got rejected. So I'm not happy. But my colleague next door, or next to trust next to me, I'm actually better than him, and he has got a very supportive consultant, very close friend who was happy to sign anything for him without actually seeing the forms inside the EPA. So there will be a clash, I believe. But up till now, there is no clash. So, but with time, it might, just come up with a sort of a rule that no, now please, you'll need to submit all the forms inside of the EPA. So I think try and submit quickly. Each EPA for a specialty, anything else to submit. So that's only 1 and 2. Yeah, 1 and 2, just the EPA forms. Obviously, the general ophthalmology, you need logbook as well. Yeah, so a logbook of cases. You need some CBDs as well, and all of this is mentioned. So we are mentioning here. So if you go to general ophthalmology, there, these are the forms, which again you don't need now as general, every 1 or 2. But then down there, mandatory requirements. Again, you need CBDs and logbooks and all of that. Yeah, so you still need those types of evidence. Yeah. Fine. What else? No SIA. What do you mean no SIA? So the SIAs are the specialties. So for the specialties, you need an EPA for each. Yeah, EPA level 3 with the evidence inside. Yeah, so the evidence inside the EPA, which are the forms, you need them. And obviously, if you're aiming for level 4 as well, you'll need those forms in addition. Okay. I hope that answered the question. Has anyone got any other questions that you'd like to add? Muhammad, you've got your hand up.
Hi. Yes, Mustafa, thank you for the
Relax my
session.
voice a bit. Yeah, go for it.
You said the evidence cannot be done retrospectively. However, on the SSG PDF file, they say on page 8, assessments and appraisals cannot be signed off retrospectively. So they don't mention logbook. Does that mean that logbook can be done retrospectively?
Right. So what does it say? Not appraisal again?
It says assessments and appraisals cannot be signed off retrospectively.
Right.
They don't mention
Yes.
logbooks.
Yes. So logbook, by the way, does not need to be signed. Okay. A logbook is just a logbook. It's just a piece of paper. It's not a work-based assessment. It's not an assessment. A logbook is your own effort as a summary of your cases. Yeah. What needs to be signed is the verifier form, which is the general form that you're going to put all of the evidence from that particular hospital, and then the verifier will sign that, yes, I've had a look at all of Muhammad's evidence, and I can confirm that all of these are true, whatever that evidence is. So you don't
So
need to sign the logbook.
technically it can be done retrospectively.
Of course.
Logbook.
Yeah.
Okay.
Why not? A logbook is just
Yeah, exactly. Because
yeah.
all the surgery I've done.
Yeah, it's a
I'll
record
go through it.
of your cases, whether they're in
Exactly,
clinic or in theater. So they don't need to be signed, and they can definitely be. I mean, they actually have to be retrospective because, the best way to actually, have the patient in front of you and then your PC with the file open, and then you can add the cases as you go along. But that's impossible, So there's no time in the clinic. I'm sure it's the same in Tunisia. In the UK, we don't have that. We don't have that time at all. So you have to do it retrospectively, at a later date, just to gather the previous cases that you've seen. But it will take some time. If you've got a good record system, you'd have to go on the system, look for the cases, and add them, and then go back and forth, and avoid repeating the cases and so forth. So it will be the step that takes most of the time. I think the logbook. That's why the case histories is a very good alternative. Case histories are less in number, but more detail, just stronger than the case logbook. And I think the best thing to do is to get a mix. Yeah, so maybe in level 3, specialty, you get, I think, 5 CBDs, and then maybe 20, 30 cases in the logbook, and maybe 5 case histories, and 5 patient letters, for example. So that's a good mix, to show different, involvement in various cases. So yeah. To answer your question, you definitely do not need the logbook to be signed. You don't need the appraisal to be signed. I'm not sure. Do you do appraisals? Do you do like an annual assessment?
No,
Wait.
we don't
Yeah.
do that.
My suggestion is to get, I mean, I can send you one later, maybe a copy or an example of an appraisal that we do here, just to get a feel of how are we assessed on an annual basis. Yeah, so there's lots of points that we get assessed on, and then you can write up a similar form and use that. So like an annual assessment, are you, we do the appraisal just to make sure that we're progressing. Yeah, we're not static, we're not getting worse. So just to get revalidated with the GMC every 5 years. So and you need to do that annually. So the trainees do an ARCP, they call it, but then for non-trainees they do an appraisal, whether you're a non-consultant or a consultant. And then it tests your, your teaching, your education, your audits, research skills, conferences, CPD points, and then comes up with a plan, like a PDP, which we'll discuss for the exam, by the way. They do ask these things. It's all GMC guidelines. Yeah. So how is a doctor assessed and improves in their practice, in their
Yeah,
training?
personal development
Yeah.
plan.
PDP.
Yeah.
Yeah. So maybe read about that. If you can find a template
Okay.
online, just use that and get someone to sign off an annual one for you in the past, 3 years or whatever, how much evidence you want to use. Get one every year. It just shows that you've got a plan and that you're developing, yeah, every year. Very important, I think. Appraisals
Okay.
are very important.
Thank you.
Do we need to attach clinic letters in level 3? I think so. Obviously, if you're in the UK, there's no excuse. If you're outside of the UK, sometimes you don't have patient letters. So I don't think you can do that outside the UK. But in the UK, I think you should. Yes, I've read that somewhere that 20 letters in level 4. Yes, I'm not sure if it's mentioned in level 3, but still you need it. The question is why not? So Neha, you're asking, do we need it? Why not? I'm sure if you've seen the patients, you work in the UK. I don't know if you work in the UK, but if you work in the UK and you've seen the patients, I'm sure there are letters. So why not attach them? You're not going to lose anything. If you're not in the UK, then obviously you won't be able to, because most countries do not have patient letters. So that's fine. In that case, you need to submit other evidence like CBDs or, again, a testimonial from the consultant confirming that you've attended these cases and you've done that and this and so on. Anything else? Does anyone else have any questions? Is there any guide, please, for how to do the appraisal and should everything included be signed? No. Okay, so again, the appraisal does not necessarily have to be signed. All right. The appraisal is again a document. Not sure. I don't think I've got an appraisal here. I don't want to show everyone my appraisal, but let me have a look. Let me see. Let me pick a nice appraisal. Hold on. Okay, let me show you this one. Perhaps it might. I think this is one of the first appraisals I've done. That was an Aintree. That was back in 2019. That was my first year in the UK. Way back. So again, this is a local clarity, it was called, one of the different forms and softwares for appraisal. So it basically tells you about the scope of work. I was the medical retina fellow back then. What clinics was I doing? So roles, job plans. So what was I? What were my duties? Yeah, again, reflection about that. Okay, PDP. Obviously, this was empty because that was my first year in the UK. Yeah, but if you're doing regular PDPs, you will mention here the previous PDP. Why? Because they want to know that you've achieved the points there in this year. Yeah. So last year I mentioned I'm going to pass the FRC off the exam. So that was mentioned last year's PDP. This year I've achieved it. Yeah. For example, you're going to put the CPD points, for example. So again, any courses that you've done, any conferences, assessments that you've done, e-learning, whatever. Yeah, teaching you attended. All of these are CPD points. So you will mention them all here. Yeah. What is the next section? Quality improvement activities, I haven't sort of done much there. Audits, you've done audits, you've mentioned there. Quality improvement activities, research. Again, I haven't done much research in my fellowship. Significant events, that's an important. So I haven't been involved in any significant events, which is important. Learning events, if any, any complaint, for example, that happened, then you again mention it here and reflect on it. Why not? Feedback, very important. Procedures, what sort of procedure have you done? Whether they're lasers, injections, surgeries, whatever. Achievements, and then the statements of the appraisee. That she was my appraiser, and she mentioned that I haven't got any concerns about his progression, basically. And then that's extra sort of points that you need to write down, and then summary, and that's it, more or less. So I think call it like a summary of your progression per year. Yeah. So every year you need to come up with a form, and I'm sure there are templates out there. Even on ChatGPT, if you go to ChatGPT and write down, please send me a template for an NHS non-consultant appraiser form for ophthalmology. They will send you a document, I'm sure. I'm not even sure if there's a template on GMC. I don't know. But this is the whole point. You get the idea. It's like a summary of what you've done in that year. Have you achieved what you were planning to achieve from last year? If you haven't, why did you not achieve it? And what are your plans for next year? So next year's PDP. That's very important as well. And try and put achievable outcomes, not for CESR. So ignore CESR for now. I'm talking about the actual appraisal. If you are working in the UK, all smart objectives. So do not say I'm going to improve myself in research and do 20 publications. Yeah, you just say I'm working on this project. I'm aiming to submit that publication in June next year, for example. So very specific and smart objectives. Fadi, you've got your hand up.
Can you hear me?
Yes, I can.
Yes. It's better to uh, elaborate on my question further.
Of course.
See, I was asking about the EPAs because the trainees, they've done that all the time and they've got experience with it. And we're not experienced with the EPAs. Can you just walk us through it if you believe, if you know how it goes now with the new curriculum? So I've done everything that's probably on the Excel sheet sent by Rob, done the
Yes.
DOPS, done all the OSATs, and probably had the case-based discussions and wrote like 30 cases that I've seen summaries, and I've got the clinical letters on the side. So if I've done all this and I want
Yes.
to finish, say for instance, neuroophthalmology, all of it as an EPA.
Yes.
So I go to the consultant and we do the EPA together, right?
Yes, correct.
Yes. And he ticks the boxes. Is there anything else from the 7 domains that was mentioned that you have to include in neuroophthalmology, for instance? Or is it done by the EPA?
Yeah, so
Like this being that,
the EPA will cover just the patient domain. Yeah, sorry, the patient management. These are the SIAs. These are the subspecialties. Yeah, that's the EPA. We've mentioned that the rest of the domains, which is from 2 till 7, there's 7 in total, I think, these are the GSATs form. GSATs is different. GSATs level 4. That's a separate form, again, covering research, communication, teaching, leadership, those sort of other things. Yeah. So these are separate. These will not be covered here. They will be covered in the other GSATs form. Okay. But for the EPA, particularly, you need to sit down with the consultant and go through box by box, and they need to show, and you need to show that you've submitted the evidence for that particular outcome.
yeah.
Like
So
this
so
one.
the
This
consultant is not gonna help. So the consultant is not needed to sign anything else besides the EPA in that subspecialty. All the
uh,
other stuff with the
no, no,
with
yes.
it's not related to him.
So obviously, that particular consultant will sign off their specialty. Yeah, so it has to be a medical retina consultant, for example. This is an MR, so it has to be a medical retina consultant. And for sure, they've already worked with you and they've signed off other things for you, so DOPS or OSATs or whatever. So you will write down here that, yes, I've submitted this DOPS, and then the comments might be from you or from the supervisor saying, oh, yes, Fadi has done this. He's shown this. He will provide 2 DOPS in this outcome, something like that. Yeah. So they still need to sign other forms. But we discussed before that technically they don't need to actually sign by their hand. Only their name is enough. But I'd still suggest you just be on the safer side and get them to sign if possible, especially if you're getting evidence from outside of the UK. Yeah. So just be careful of that. Just do not, you know, just write their name and that's it. Just try and get them to sign if possible.
So just to summarize, they're not involved in the other stuff. Like they're just involved in patient management, right?
Yeah, but still, you still need the GSATs. The GSATs would be 4 different forms, any consultant. Okay, so it doesn't need to be a specific consultant in a specific specialty because these GSATs are not covering specialty. They're covering, let's call them non-clinical stuff. Yeah, so any consultant, 4. You need 4 of them.
Can we do them after the SIAs anywhere else?
Yeah. So yeah, exactly. So I mean, I've hold on, GSAT. Let me show you the GSAT. I've showed it earlier, this one. And only level 4, yeah, because again on the website you'll find 4 of them. So level 1, 2, 3, and 4. You just need 4. So ignore 1 and 2 and 3. I just need level 4, and you need 4 of those. And as you can see, it covers weird stuff. So health promotion, leadership, safety, safeguarding. So for example, supporting safeguarding. Yeah, that's a trainee self-assessment. You'll say, I've signed off a CBD about safeguarding. I've seen this case. I've reflected on it. Maybe write a reflection, or maybe signpost the assessor saying, please see reflection page 5, and then the supervisor. And then they say, oh yes, they can meet the expectation, and add a comment. I've seen them do this. We've discussed safeguarding. They're proficient. They know what they're doing. Whatever. Yeah. So it's like a discussion. You're recording the discussion with a consultant, but it's flexible. It doesn't need to be a specific consultant to sign off GSATs. Obviously, try and get different consultants. Do not get the same consultant to sign more than one GSAT. It just doesn't make sense. So get 4 different people to sign the GSATs for you. Yeah. So it's easy. It's not tricky. But just make sure that you've covered each and single, row. Each outcome needs to be covered.
Okay.
And whichever, it's very flexible. You can cover it with letters, courses, testimonials, whatever, as long as it's, justified. Does that answer your question? Does that make sense?
Yes.
Yeah. It's easy. It's not tricky. Honestly, the new curriculum is much easier than the old one. Just that the downside is that there's very specific questions that we don't know the answer yet to, and no one would. I'll be lying if I tell you that I know the exact answer, but time will tell, I think. Someone was asking. Hold on. Even if I haven't done the appraisal in my previous trust and now need to do it in my new trust, would that still be okay as they haven't observed the previous progress themselves? Yes, because yes, it doesn't matter because, like for example, in my first appraisal, I haven't done a previous appraisal and the previous PDB is not there. I haven't had a previous PDB. Yeah. So if it's your first appraisal, that's fine. You're just going to put a new plan. You're going to put your job plan, your teaching, your progression, and then propose a new PDP for next year. And then, as I said, smart objectives. The appraisal is very important, in my opinion, again, for those outside the UK, very important because they want some sort of annual assessment. Similar to the trainees, we always try and mimic the trainees. They've got an ARCP every year to make sure that they are on track. Very similar to this. Yeah, so need to come up with some sort of, or another option is an education supervisor report. That's another one. Very similar to an appraisal. It's not always an option for everyone, unfortunately. I think non-trainees should have an education supervisor, but it's not always the case. So if you don't, that's fine. Just get the appraisal in your application, and that's it. For those overseas, if you want to do an appraisal, great. If not, then just do an education supervisor. It's just a similar process. An annual assessment. Call it an annual assessment. Can I ask for all portfolio if they mentioned FRCOF as evidence? I need to just CBD or DOPS as second evidence. It will be enough as general example I'm talking. Yes, but not DOPS and OSATs. Remember, FRC-off does not take off DOPS and OSATs. All right, it will take off other stuff. And I'm sure you've seen that Excel file somewhere, with the red, green sort of traffic light system, where it tells you that the FRC-off can be considered as an evidence of that outcome. So one box ticked. Now you just need one other form, and that's it. But these are mainly for the non-practical stuff, so not DOPS and not OSATs. So the PI, the PM, the HPDP or whatever, those can be assessed and signed off by the FRSoft. You just need one extra evidence and that's it. Should I do 10 CBDs for each specialty? Again, no number, even if the old one. I think 10 is an average number. I'm sure you will do 15 in one specialty and only 5 in another specialty, so which is fine. But don't do 15. I think 15 is too much. I think 10 is an average. Or just stuck at LO in Excel sheet. What do you mean by that? Aziz, I have no idea what you're talking about. But yeah, just 10 CBDs. Okay, so maybe aim for 10 for the old one. As I've said, in the new one, I'd suggest 5 maybe, level 3, and if it's level 4, then maybe aim for 10. I think that would be an average number. But I can see lots of new names out there. Again, there was many more a while ago, but it's quite good that there's new faces, out there, and it's getting more popular. So it's quite reassuring. And if you are on the groups, I think it's quite motivating to see lots of people being accepted. Yeah, and obviously, without mentioning names for sure, lots of people there I know very well, and their applications weren't great. Okay. And I was kind of sure that they would come back with recommendations, but actually they went through. So I think it is more flexible now, especially with the new curriculum. So to put your hopes up, it's always good to motivate yourself, and that's why we're doing this, just to keep everyone on track. I think it's getting better. It will become more flexible, and it's getting easier. We need consultants. Yeah, so I think it's a golden opportunity, especially with the new rules coming in, and the people not able to get into training and stuff. So I think that will affect the jobs, and there will be more jobs in the future actually. So I think it's an opportunity. So do not postpone. Again, for sure, over the next few months, lots of people will submit through the old curriculum before the deadline. So the GMC and the college will suffer from an influx of applications all of a sudden, even if they're not complete. Okay, so because everyone wants to join with the old curriculum for whatever reason, they want to get it done. So my advice is apply. Yeah, submit sooner rather than later, before it gets busy. You'll just delay yourself for no specific reason. So just do your best on that aspect. Right, I think that is enough. I hope that's been useful. I'm always happy to repeat this session in the future if necessary. I will upload this session on the YouTube channel very soon, hopefully, and share it on the groups. Thank you everyone for attending, and have a good night. I'll see you soon. Thank you.